waiting so long and attending this late session. And I would like to start by thanking the organizer for inviting me to come and present this topic, which is important for us to be able to address the big concern of pregnancy. Now, it's important to address this concern, try to understand. We are talking about trying to get the obstetrician and the nephrologist to agree. Here I realize that you have to bring the immunologist in order to understand what the processes are, as we will see later on. They're going up. So I would like to address this topic by going back to the definition, because we have to know what we are going to treat and what we are talking about, and then spend some time on pathophysiology. I'm glad that a lot of talks that were held this morning address the issue of definition and treatments and so on. I will touch to that aspect only later, and then maybe point out what are the differences that we have to be specifically applying in the context of pregnancy. Now, in terms of the definition, one should, first of all, recognize that you may have in Africa, we expect that about more than 25% of the population may be hypertensive. So obviously those patients can become pregnant and eventually you have to deal with how you deal with hypertension during pregnancy. And then what we have also is how do you diagnose, what's the definition in terms of in that chronic condition? It could be as predating pregnancy, as we see in the general population, or you can say that if it's a gestational pregnancy, so you need to happen after 20 weeks. So if it before 20 weeks, 20 weeks is the cutoff time that you have to distinguish in terms of the definition. If not, if more than 20 weeks later, you talk about de novo, and you have either preeclampsia or just gestational hypertension, which arrive after 20 weeks. And you may have a true gestational hypertension or a transient one, which is making it more complicated because you may have just elevated blood pressure in office, which is what called hypertension that we'll touch base later on. As I indicated that what called hypertension, which can be elevated only in the clinic or the office, so one had to make sure that you get to the diagnosis properly, and we'll see later that you may need blood pressure monitoring. And that not to make things simpler, then you may have masked hypertension. What is masked hypertension is the opposite. You have a patient come to the clinic, the blood pressure is normal, but if they measure the blood pressure at home, it's elevated. So that's the spectrum of what you're going to deal with. So that said, this busy slide says that a lot of society that have been dealing with hypertension, as you can see from the left to the right, from American College of Obstetricians and Gynecologists, talking about hypertension in Canada, European Society of Cardiology, and you name it, you have a lot of hypertension interest. Now, what we decide to do is maybe to concentrate the more international society for study of hypertension define in terms of the category that I alluded earlier, the chronic essential hypertension, secondary, which was covered earlier today, and you have what I just explained. And then in terms of the definition, they are more or less similar. You have to consider that established blood pressure about 140 for the systolic, and diastolic about 90 is considered hypertension. It becomes severe when you are above 160 for the systolic and 110 for the diagnosis. So usually confirm within 15 minutes. So let's go on to the pathophysiology. So this is an important slide. I'm going to try and go through it slowly so that everyone can understand. This is a key problem when it starts, is placental ischemia. As you know that the placenta will be the interface that can allow the maternal tissue, maternal body to interact with the developing fetus. So it must be adapted in order to respond to the needs of the fetus which will be being created. And you have oxidative stress, which is through mitochondrial stress, and on the other hand, you have persistent hypoxia, which will then affect in one way, or the long term being leading to small gestational age infant, what you don't want to happen. Now, why is it coming from? For you to end up with placental ischemia, there are many factors, from the genetic factors, the maternal environmental factors, and immunological factors. The genetics, maternal factors, and fetal, that's have been described quite some time. The decidual transcriptome, that involved all the RNA and that are produced there, eventually leading to the protein that have been involved, and the hip oxygenase isoform imbalance, that all will affect the placentation, the development of the placenta, and will lead to ischemia in the placenta. We have the maternal environmental factors, smoking, diabetes, and so on, will also affect the development of the placenta, and last but not least, the immunological factors. And here, what you must understand that as the immunology, you have Th1, Th7, and the regulatory path factor that will be discussed later. You have immunogenic HLA, if the on trophoblasts can affect. And this is an important aspect, I will see later, decidual natural killer cell. They play an important role in immunology's footprint. All of that will then affect the circulating S-fleet and the S-Eng. So will then increase the syncytial debris and pro-inflammatory cytokine in maternal circulation, and leading to vasculopathy, obesity, and SLE can then eventually affect the systemic vascular dysfunction, leading to proteinuria, hypertension, visual disturbances, and HELLP syndrome. So that's overall what you should be seeing. It's quite complex. I thought that it may be important to spend a little more time on what the nitty-gritty in that respect. So this, to understand, you have to start with the middle. This is the regulatory NK cell that I alluded earlier. It's important in normal pregnancy. What happened? The regulatory natural killer cells, which are can interact at the frontier between the trophoblast, dependent spiral uterine artery remodeling, because you need remodeling of your placenta to grow, to respond to the changes that are required for the fetus to grow. And for that, to influence the trophoblast cells, you have the intervention of IL-8, IL-10, and IP-10, in order to be able to trigger migration, because you have the cell that migrate and then set up the development of the placenta. This is a normal phenomenon, a normal pregnancy. So at the same time, on the trophoblast independent remodeling, you need aggregation around the remodeling vessels. The vessel have to come to play, and where the importance of the secretion of matrix metalloprotein 7 and MMP 9, and the vascular muscle, that smooth muscle cells, that's important, and endothelial cells. And you need apoptosis, because with the changes in the modeling, you need those cells that no longer require need to be destroyed in order for the new cell to come to play. So that's important aspect. So that's what you should expect, how we will do a balance between the two. Now, for you to be able to make sure that this phenomenon, the regulatory natural killer cells, they need to make sure that because you have two populations living together, maternal as well the fetus coming, it's important to avoid any type of rejection to make sure that there's tolerance. So how it's built is that the regulatory natural killer cells will interact with CD4 cells to trigger the T regulatory cell. They will be converted to T regulatory cell and keep in balance with T17. Now, if you have any problem with preeclampsia cells coming to play, they will decrease the T regulatory cells, meaning that you will decrease your chance of regulatory, which is immunosuppressive, to allow the maternal body to accept the development of the fetus, so you can have rejection of the baby if this continues. And on the other hand, it increases the Th17, which is pro-inflammatory. So meaning that this part of the equation is that trigger to more inflammation and leading to hypoxia, because then you have poor blood flow. That is the phenomenon in the background, what's happening during a preeclampsia. Again, and the other, it can also affect the migration, meaning that affecting the development of the placenta. So those are the phenomena that occur. This is just a summary of what we have, we just discussed to make it in schematic form. Placenta hypoxia, which is important, trophoblastic invasion, or the spiral uterine arteries, and will then with TGF beta 3, and the factor which are involved in the placenta, which is involved with hypoxia inducible factors 1, and angiotensin factor will be also involved. All of that will lead to the ET, which are endothelin factors that will be the center here, will be an increase. And this is important because then you can have option trying to reduce the phenomenon. If you look at TNF alpha, which is kind of pre-treatment, can then affect on those areas. So one can assume that in that context, when you are increased production of this, you can then intervene in that area. Again, is a summary of what was sent even earlier, the preeclampsia clinical syndrome, hypertension, glomerular endotheliosis, proteinuria, which is important because as far as I know, it's maybe one of the important markers that stood the test of time, proteinuria. I think we have to pay credit to proteinuria all the time because it's the simplest test that we can pick up and for generations through the end of time. So you end up having lipid capillary hypertension and eventually severe preeclampsia syndrome. So that's basically what one should understand in terms of the pathophysiology. This is a more simpler term. I won't pay more time to that. Here again, another summary that simplify everything, plasma ischemia always being the center of the process leading to placenta release factors and the summary endothelial activation and dysfunction that will occur, and eventually causing hypertension. So that's why high hypertension happens. Again, this is more simple for us. So now we think I've covered what are the issues with leading to hypertension. Now my second task is to see how we're going to address hypertension. I'm fortunate to be speaking among the last people because hypertension has been covered since the morning. Maybe I should stop there. Nonetheless, I'm still going to point a few specifics in terms of pregnancy. Now, let's go back to it may be easier to view to address the problem in looking at principle so that you can understand what's happening. So, yes, we talked about chronic essential hypertension. So what are the targets? So if you can maintain your blood pressure between 110 and 140 systolic and 85 systolic, this is the recommendation for the International Society. This should be in good shape for your pregnant patient. Now, the choice of drugs, that's important. The first-line drug, labetalol, propranolol, methyl dopa, which is what widely used, nifedipine, and the are still recognized as the main first-line treatment. Now, if that failed, then you can move to adding prazosin and hydralazine. Those are the recommendations which were published last year by the International Society for the Study of Hypertension. Now what is important, I mentioned that home BP monitoring. I spent some time trying to present what's called hypertension, Y-code hypertension, where the blood pressure is actually more in the clinic and the office, but less at home. But some patients may have blood pressure high during the night. That's why it's important to monitor blood pressure at home. Now we have automatic blood pressure machines that are more fairly reliable, so we encourage our pregnant patients to carry blood pressure monitoring and then check at least blood pressure. We'll see. So, but it's very important to monitor signs of hypertension. Urine analysis looking at proteinuria, check hemoglobin, platelet count, liver transaminases, uric acid, and creatinine. It's important for us to assess fetal well-being with ultrasound from 26 weeks of gestation, because the sooner you say that there's a problem with fetal development, then you can intervene. And we should deliver, as we discussed earlier also during the first talk, saying that the nephrologists want the baby to go out as soon as possible. I remember when I go to the obstetric ward to see a patient, my first question to see, when can this baby come out? And now I remember that 37 weeks seems to be the magic number. I say, well, so we have to make sure that the obstetrician want to keep the baby at least until 37 weeks. That's what they feel safe and so on. Otherwise, if there's no problem, they want to push to 39 weeks, then they're more confident to allow the deliveries. I think that's important in terms of practice. So those are the basics for hypertension. Now, if it becomes serious that the blood pressure is high, we may have to revert to more potent drugs like labetalol intravenously. This is the dose you can then use. Outpatient, you can then go back to lower doses. You can use hydralazine, which is a good drug that in the setting of urgent BP lowering, and nifedipine as well, immediate release, which is important. So those are the tools that you should use if you have severe blood pressure that need to be reduced. And eventually, you can then look at following that acute phase to go more on to the chronic phase we can control. That's where while methyl-dopa is not used in acute phase, you can then look at, on the continuation phase, you can revert to a methyl-dopa, as you see there. Now, I talked about what's called hypertension, and this can be used in order to control, is it truly what's called hypertension or not? So BP, 24-hour BP monitoring may be what we should use, allow the patient to wear the BP machine monitoring, to establish whether we have the blood pressure being high. Those are the levels that are accepted according to International Society. If it's the diagnosis is persistent, when the patient wake less than 130/80, if it's more, then you talk about hypertension. If not, white coat hypertension. Those are the two balances. The cutoff will be 130/80. And look at the difference between being awake and at night. At night, the BP is much less. So if it's just more than 115 over 70 at night, you consider that diagnosis of hypertension can be established with the risk of 25% of preeclampsia, bearing it in mind. And of course, you have to monitor blood pressure if blood pressure become apparent, and so on. So those are the things that I think which are relevant that you can use in our context and try to diagnose hypertension and then manage accordingly. Now, I would just to mention as in the context of renal failure, when you are in a renal congress, So when the renal chronic hypertension because of renal disease, that unfortunately can happen. And what do we have? We have, in this condition, maternal fetal outcomes are worse than in general population. So everyone knows that if you have a patient who have renal disease and decide or fall pregnant, it's very difficult. Then you have something to manage. And if the patient doesn't want to keep the baby, then you have no choice. You have to accompany the patient and try to do your best. And you have to control blood pressure, which is important to pregnancy, because both for pregnancy and for maternal renal function, and as well as monitoring any early cause of preeclampsia. And if, unfortunately, during the process of monitoring the patient, the renal function deteriorates, what's next? And you have to dialyze. It's a very challenging dialysis. We have, this year, we have 2 patients that we have to follow up, became pregnant after, unfortunately, in this context of HIV infected as well. And when we are called to the obstetrics ward, we are hoping that they were close to 37, but unfortunately they were at least 8 weeks prior to that. We are for 2 months dialyzing the patient, and what to do, we have to see how to dialyze the patient pregnant and making sure that the patient delivers. Luckily for us, we dialyze the patient. Now the recommendation is to do dialysis at the dose of 36-hour dialysis per week. So we managed for our patient, 2 patients, to give 5-hour dialysis for 5 to 6 days. So we managed to get away with 30 hours. The patient was stable, and then the delivery went well, luckily. So now, again, this is a busy slide. That to tell you that everyone have contributed. You are welcome to go over that when you get those slides to try to see what the difference. But essentially the same that we have presented here to have in terms of the treatment and the management as well. So with those few words, I just had to invite you. I'm the president-elect of the South African Renal Society, and I'm in charge of organizing the next Congress, which will be in Durban next year, and invite all of you to come. Thank you.